Ripa ma'am,
Ripa,
please
please
start.
start.
Yes. So, good evening, everybody. On behalf of Maha IIP, I welcome each one of you for this splendid episode number 6 of Learning with Legends. And for this episode, we have yet another legend, a renowned senior pediatrician from Mumbai, Dr. Sridhar Ganpati sir. Sir may not know me, but I have been a student of Ambedkar sir and I have attended science clinics where sir used to actively teach us. So I'm very happy to moderate this session for you, sir. And I would like to now invite Dr. Ram Gopal sir, Maha IIP president, to please share a few words with us.
Thank you, Dr. Ripa. Good evening, friends, and welcome to another episode of Learning from Legend. As the title itself is explanatory that we will learn something from the legend. So today we have a very, very big legend, Dr. Sridhar Ganpati sir. Welcome, sir. Sir has got a 3-page CV, so difficult to read, but I would like to say one thing about the today's topic. I was listening to sir in one of the talk where he just said a few things which are normally not taught us, like pH of a certain substance, food item affects the absorption of another food item, or it might cause a nutrient loss. So that was an interesting. At the same time, he said few drugs also causes slower absorption or may affect the absorption of a micronutrient of the foods what we are eating. So then that day I realized, okay, this is very interesting topic. I think we should learn more about it from the sir. So I discussed with the sir, and I think after 3 months of nagging him, he agreed to give me this time. So thank you very much, sir. And I welcome you. We welcome our past CIP treasurer, Dr. Samir Dalwai. Welcome, sir.
Thank you so much. Thank you.
And Dr. Singari, he is from not from Maharashtra, but he is from other states. So welcome, sir.
Andhra Pradesh.
Andhra Pradesh. So welcome, sir.
Thank you.
Now, Ripa, over to you. Unmute. Yeah.
Ripa, first, I would like to request Dr. Samir Dalwai sir to say a few words. Samir sir, please.
Namaskar, Sarvana. And thank you so much, Dr. Ram Gopal, Dr. Amol sir, for this wonderful occasion that you have done. And I just want to say one thing about Ram Gopal. He said I was going to write. The thing with Sridhar bhai is that when you hear him say something, और राम गोपाल आपके ठाणे में मैंने कॉन्फ्रेंस में सुना था उनको, he spoke about sleep disorders. And I was so fascinated. At least 4 places I've invited him to speak about this topic. And every time I hear him, I'm trying to learn something. So what you said, Ram Gopal, is so true that when we hear him speak, there are things we have never thought about this topic. You exactly said the right thing. And that is the great essence of Dr. Sridhar. He's a brilliant academician. And more than that, such a wonderful, down-to-earth, humble human being. So all the best, but pleasure to listen to you. Thank you so much.
Thank you so much, sir, for your encouraging words. And we are really waiting for Sridhar sir's yet another fascinating session with a very intriguing and amusing topic, which is prescription-induced nutrient loss. I don't know. I myself don't know. Is it something hydrogenic, idiopathic, fat loss, or I am really confused. But I'm sure by the end of this session, we all will be enlightened and we will be knowing much, much more about prescription-induced nutrient loss. And I hope this will translate into our prescription writing habits. So I would now request Sridhar sir to kindly begin his session. And sir in the beginning had only told me that very kindly that he requires no other introduction other than being a pediatrician and of course also now a sleep expert.
Ripa, just 1 second before we start. I think our Maha IP secretary would want to say something.
Okay.
Yes,
I will. So First of all, welcome Dr. Samir Dalwai sir, past Central IIP Treasurer plus Joint Secretary Admin from Mumbai. He is the main person uh, who is handling the IIP Ki Baat Community Ke Saath. Excellent initiative by Team Basavaraja sir this year. And then I also welcome today's guest expert, legend, Dr. Sridhar Ganpati sir, Dr. Amol, Dr. Ram Gopal Chedara sir, Dr. Prabhakar sir, and all the pediatricians who have joined from across Maharashtra as well as India, and also PG students. So this is very nice initiative conceptualized by Dr. Our Bhavesh Mithya sir, scientific convener of Maharashtra IIP, and Learning with Legends. So name was Learning from Legends, but later on we thought that Learning with Legend will be a proper word, so we changed that. And a lot of experts, faculties have came here, and lot many inputs we have got from them about how to practice and how to go ahead with the ethical practice and all these things. Dr. Sridhar Ganpati sir is one of them, and I heard in 2018, I was secretary of Nashik IIP, and at that time, Dr. Reddy have came with some innovative product, this protective drops, this probiotic drops, and he happened to be associated with them, and he came to Nasik to give that 1 hour, 1.5 hour lecture, and I was so fascinated with his talk and his in-depth knowledge about pediatric gut health that till now I am listening to him on various platforms, various other platforms in conferences also. So welcome Dr. Sridhar Ganpati sir, and I wish all the delegates happy learning, and over to you directly now. Sridhar sir, please.
Thank you so much. Can I share the...
Yes, sir.
Okay, so first of all, thank you, Ram. And I'm sorry I postponed it for such a long time. Thank you, Amol, for the introduction. Thank you, Ripa. You have been very kind. And Samir Bhai, as we call him, don't take it in the wrong way. He's like a brother, and he has always been supportive right from the beginning in all that I have done. Thank you, Maha AP, for the importance, but I basically feel that particular word LEGEND, the legend thing, should be removed, because I think this is a platform for sharing knowledge. And I think there are youngsters who have picked up so many things. It is only that the wisdom that we get over time, that we start using and we start sharing with the juniors, that gets us to this level. That's the only difference. And I am not ashamed to say that even today I'm still learning pediatrics. And my teacher is Dr. Amdekar, and I don't mince words. We all require a guru who will show us the way as to how to practice pediatrics and to learn the pediatric medicine. They just see, when you open a textbook, you start with a diagnosis. It's very easy. But to come to a diagnosis, you require a guru. And I don't think, I'm really lucky, and I pray to God, and I'm thankful to God that I've got Dr. Amdekar as my teacher. So my topic for the day is a little bit astray or away from the routine topics that are discussed. It's prescription-induced nutrient loss. And you won't find this much on the net, but if you write drug-induced nutrient deficiencies, you will get it. So I've put it as prescription because the prescription is written by us, and we never think of the collateral damages that every prescription causes. Every prescription can lead to multiple collateral damages, and this is just one aspect of the damage that a prescription can cause. So it comes under the umbrella term of adverse drug reactions, and it's poorly appreciated, one of the poorly appreciated part of ADR. And I have made it into a short form called as PIND or PIND. It's nothing to do with the Punjabi word, which means a group or a village. So it's prescription-induced nutrient deficiencies. And when you look at the genesis of any disease, today we talk about the host and we talk about the exposome. So when you talk about the host, you need to know about his genome, the epigenome, that is a genome which interacts with the exposome, and the microbiome. And when you talk about the exposome, we talk about geography, we talk about the diet and the lifestyle. And let me give you some examples. So when I talk about the genome, now for a drug, we are entering into an era called as pharmacogenomics. And this is something which is very important because I may require just one tablet of paracetamol for my fever. Throughout the day, somebody might require up to 6 tablets based on his metabolic capacity. So now we have started decoding the genome. And if you do have a deficiency in NAT, N-acetyl transferase, you would know that an isonex may create trouble in you. Same way, how does the genome interact with the exposome? Gives you the epigenome. And then when you look at the microbiome, this has come straight to the front. It has assumed so much of importance today that even for a drug to work, toxicity of a drug, everything depends on the microbiome. It's an integral part of us, and we have now realized that the microbiome has a genome which is almost 150 times the human genome. So it has a big role to play, and one of the easiest or the most easy thing to manipulate in a disease is the microbiome. Then when you come to the exposome, why do you require to know geography, diet, and lifestyle? Let me give you examples again. So when you look at geography at present in Bombay, it's so hot and humid, and we are sweating it out. Anything which causes excess of sweating is going to bring down your electrolytes, and you're also going to have a low level of zinc. Added to this, if you have a diet like the way we eat in Mumbai, which is full of phytates, again, you're bound to have an increased deficiency of zinc. And a fall in the zinc predisposes you to CMI defects and a number of disorders right from gastroenteritis. Then comes lifestyle. Lifestyle, I talk about things like smoking, alcohol. We all do know that alcohol is a very potent inducer of a metabolizing system in our body called as the cytochrome system. So it's an inducer. So a drug may not work to the same extent like it would do in a person who's non-alcoholic. This is something that my teacher keeps telling everyone because today we are in a world of medico-legal problems. It's all safe pediatrics. And your prescription should start with a diagnosis. So if I write malaria there and then write quinine on this side, then even if the child gets a side effect, I am safeguarded because I have a diagnosis and I've given the quinine for the diagnosis, which could be a clinical diagnosis. Medications, yes, prudent use of medications. Just like in fluids, less has become more. The less number of drugs in your prescription, the more is the effect. And last, even the duration. The less the duration, the better. And let me tell you something out here in the diagnosis. So if I gave a diagnosis of malaria and I gave quinine, we used to see at that time, I passed out in '89. And in those days, when quinine was used, and we used to use it with doxycycline, and we used to see a lot of drug-induced esophagitis because these babies used to take the doxycycline in the prone position. If you had kept them in the upright position and given, this would not have happened. So common sense, a lot of common sense is required. And what we also did see is a lot of them started developing tinnitus. They were extremely anxious and they all had a sleep disorder. Significant number of them. And now we know that when you use quinone, so if you use a quinine derivative, what basically happens, it blocks tryptophan absorption. And this is something acute. You take quinine, it's going to stop your tryptophan from getting into your system. Tryptophan is converted into 5-hydroxytryptamine, which then becomes serotonin. Serotonin is needed for so many things upstairs, right from sleep. So there is going to be a deficit in serotonin. This is also needed for, is also the cause for tinnitus. So now we know probably tinnitus, probably the anxiety, probably the sleep disorder, was in a child who was already tryptophan borderline, and the quinine pushed him into frank deficiency or defect and resulted in all these side effects. So what I'm trying to say is, you need to understand that when you write a prescription, yes, great, malaria, quinine, great, but you need to know what else can happen when you use quinine, and you need to understand that the drug should not be worse than your disease. So what is the better part of this so-called diagnosis? I mean, when they did find that quinine was very effective in malaria in those days, and when it was combined with tetracycline, did even better in the falciparum malaria. And they found out now that it has the whole set of side effects which is related to tryptophan and serotonin. They have started trying it out on serotonin syndrome. So every mishap is also taken advantage of. And this is again what I'm trying to say. Who gets these drug-induced or prescription-induced nutrient deficiencies? The ones who are susceptible. So if you take a neonate, this is a period of active growth, be it the CNS, be it the nerves, be it everything. So in this period of active growth, if I give this child an isoniazide prophylaxis, it's definitely going to push this child into all forms of CNS and neuropathy. Because you do know that Isonex has a depleting effect and a blocking effect on the vitamin B6, pyridoxine. And on the right side, it's adolescence, a period of active growth where you require a lot of calcium and vitamin D. And this is the time when you have a wheezer who has to be put on steroids. And we do know that steroids not only block the absorption of calcium from the gut, but they also induce vitamin D metabolism. And if you are going to give it for prolonged periods of time, see, in both these conditions, we are going to be giving these drugs for a long duration of time. Definitely, this could have its aberrations. So you could divide kids into three categories. You could have one with optimal nutrition, the second one which is deficient, and the one in the between. So it's good, bad, and ugly. And this became very famous when we started evaluating vitamin D deficiency. So we had children who are optimal, we had children who are deficient, and we had children who are on the borderline who had to be supplemented. So based on this, I'm going to run my subsequent slides. So when you look at prescription-induced nutrient deficiencies, you have major ones, you have minor ones, and moderate ones. The major ones are usually known to all of us. So we all know that when I'm going to be using a loop diuretic, so if I'm going to be using furosemide or dorsomide, I do know that I'm going to be losing potassium. And I can't afford to lose potassium. So we supplement potassium. And this is known to everyone. The moderate one, now we know that we are going to take metformin in diabetes to improve insulin sensitivity, to decrease appetite, because it's also an anorexian. It does block B12 absorption. And there are multiple mechanisms by which B12 assimilation in the body is affected by metformin. So that doesn't mean that you straight away jump into B12 and start giving B12, because excess of B12 has side effects. So if I have an obese child who's about 15, 16, and the endocrinologist decides to start him on metformin, and he's going to be giving this metformin for a long duration of time, he needs to monitor B12, or at least look at behavioral changes, intelligence, certain things that will tell you, yes, there is going to be B12, which is going to come down. So he is ready with his B12. What happens if you supplement B12 in a person already having sufficient stores? In B12, you tend to have sufficient stores in the body. So to get B12 deficiency, it has to be a long duration effect. So when you have sufficient stores and you give excess of B12, one of the side effects that we are seeing now is acneiform eruptions. So that is why you keep this on hold. Remember, B12 deficiency can come up. You look at the blood reports, you look for megaloblastic changes, and if it comes up or he doesn't do well in his scholastic performance is affected with no other cause, you would think in terms of B12. And the last one is something that is only if you start reading. So I still remember when we were postgraduates, and it was my first NICU term. I was very lucky to have one more great teacher, Dr. S.F. Irani, under whom I did my neonatology. She was an excellent neonatologist who teaches basics in life, temperature regulation, glucose, simple things, nothing complicated. And we had these children who were given aminophylline for apneic spells, and they used to have crying bouts. So we felt, is it the headache that is being caused by theophylline? And then we got to know it's actually the hypercalciuria that it induced, which was causing them to cry. But what was not known, and when we were reading theophylline, we have realized that even the B complex group is affected by theophylline and long-term theophylline. Theophylline was a great drug. It was used in the past for nocturnal asthma, a wonderful drug. But the problem with theophylline is if 1 rupee has effect, 1 rupee 5 paisa has side effect. So the therapeutic index was extremely narrow. So that is why it is still kept on the side, theophylline and neutrophilic asthma. So let's come down to the basic things in prescription-induced nutrient loss. So you can have it by an indirect way or by a direct way. So what are the things that happen through an indirect way? One, the drug could be an anorexiant. It could kill your appetite. It could cause dysgeusia or aberrations in taste. And drugs that dry up the saliva or alter smell can also affect intake. Then drugs that cause mucositis, especially the cancer drugs or the chemotherapeutic agents that we use in malignancy. And most of the drugs, like an NSAID, a quinolone, which cause GI upset. Even I'll give you examples of antibiotics like clarithromycin. You can take an amoxiclav. They create so much of a GI upset that the intake starts getting affected. So let's take each one. Anorexians, I'm sure some of you would agree that when methylphenidate hit the market in a big way for attention deficit disorder, it was a very powerful anorexiant. It really suppressed appetite. Metformin is not only given for the glucose metabolism, that is, improve insulin sensitivity, not only to alter the microbiome, increase the Akkermansia muciniphilia, which are mucus-eating bacteria, and produce butyrates and improve the gut barrier, but a very powerful anorexiant, so that the amount of food that's eaten, the voracious appetite that those fat type 2 diabetes mellitus patients have is suppressed. And we all know about topiramate, which is given for multiple conditions. When they started giving this for migraine, they started seeing that the child started losing weight and there was a real fall in the appetite. But you need to understand one big thing about appetite. Appetite is what I like. Appetite is, do you have the time? And appetite is the right environment. When all these things are satisfied and a drug prevents you from eating food and you don't have an appetite, it's called an anorexia. Then comes taste. Like I told you, now it was always the potassium supplements, and I'm sorry I've written cital there. It is that citrate solution, dihydrogen sulfate citrate, cital, that's used in all urinary tract infections. The potassium supplements that are supplemented along with loop diuretics, and the azilastin that is now used as an intranasal spray in children above 6 years, an excellent preparation for allergic rhinitis. Azilastin leaves behind a bitter taste, and companies are trying their level best, because see what happens when you have a running nose. Smell and taste go hand in hand, and when you have a blocked nose, naturally your appetite is going to go down. Azilastin opens up the nose, suppresses the allergic phenomena, and you do very well when you use a combination of an intranasal steroid and azilastin. But the after bitter taste that it leaves behind is a big problem. Potassium supplements, anybody who's tasted K-Sol would definitely say yes, it's absolutely horrible. It causes gastric irritation, it's It's very difficult to take. So here you have a child who's got a cardiac failure, who's already vomiting, who's on all types of drugs that cause vomiting, and you add on a potassium supplement, which is so very, very essential, it can cause trouble. And same thing with anybody who's tasted the citrate mixture. You have to dilute it in water so that you blunt the taste before you can take it. So you need to look at the prescription and you need to write only things what are needed. Then comes smell. I don't know how many of you all use these as a mucolytic agent. It's a favorite among the adult pulmonologists. It's a great drug for paracetamol poisoning. It's supposed to be a very powerful antioxidant, being tried in a number of situations where the oxidizing agents or the GSH property in the body has gone down. They come as effervescent tablets. And when you put these tablets in water and you try to take it, it's absolutely horrible. It has got a garlic taste and a garlic aftertaste. When you nebulize N-acetylcysteine also, you know that this patient is being nebulized by it because of the garlic smell. So smell is another thing that decreases your intake, your appetite. Then comes saliva. Anything that causes a dry mouth. So what causes a dry mouth? Anticholinergics. So most of the first generation antihistamines which come in your nasal decongestants, the ipratropium that we use as inhalers, the glycopyrrolate which is used by the anesthetists, and now they also come as inhalers, they all dry up the saliva. And when you dry up the saliva is the most important thing that takes the compounds to the taste receptors and gives you taste. So when you have a dry mouth, it is painful and you don't get the taste. Mucositis, which we already discussed, because these are drugs, anti-cancer drugs, apoptotic, and they affect the life cycle of the cells, and the turnover is so slow, and they are all anti-DNA, and the mucositis is also very painful. Upset GI, we know that almost every drug that we write in a prescription could have this potential. Epigastric discomfort, some can cause nausea, some vomiting, you could have loose motions, or you could have constipation. And all this could be a deterrent for a good appetite. So indirect means your intake is affected. Then let's come to the prescription-induced nutrient loss by the direct method. This is very interesting. And we never think about it. And why don't we think about it? Because we are so bothered about the agent causing the disease. So when we had the Dombivli fever, which was the multi-drug resistant enteric fever many years back, quinolones came to the fore, and ciprofloxacin was the drug of choice. And there were companies who minted money by the sale of ciprofloxacin. So this was one drug which used to work for some and did not work for the other. And people started thinking, why is it that is not working for some and working for the other? So that's what I told you right in the beginning, that the less number of drugs in your prescription, the better you do. So the prescription that was written by a practitioner, let me give you two prescriptions, one written by a general practitioner and one by a consultant. The general practitioner wrote ciprofloxacin in the right dose for enteric fever. There was an MDR Salmonella typhi, which was picked up on culture. The second drug that was given was an antacid, so that ciprofloxacin did not cause any GI irritation. The third drug was a probiotic with zinc, which was added so that the microbiome was not affected. And the last drug that was put there was an NSAID in case of fever. The consultant who saw the child, the ID consultant, had a similar prescription, but had only ciprofloxacin there and a paracetamol, which was SOS, in case of fever. And it used to work in 3 days because the kill time of quinolone was very good at that time. Now we have the nalidixic acid resistant Salmonella typhi. At that time, it used to work wonders, and the kill time was very short. And it didn't work in the same prescription written by the general practitioners. And we started wondering why. And as I go through the slides, I'll show you why it did not work. The second direct effect is digestion. All our nutrients are in food matrix, and they have to be separated and freed from the matrix before they can be assimilated in the body. Absorption, you require an intact epithelial surface. And in the epithelial surface, you have transporters, you have enzyme systems, and these transporters, there is competition for it also. So these transporters can be induced, that can be inhibited by multiple drugs. And you also have a cytochrome system sitting at the epithelial layer to metabolize various drugs. So metabolism, and last is excretion. Excretion is either by stools or by urine. So coming to the luminal, I have called them the chelators. And we all knew that when we used to give a tetracycline or a doxycycline in certain conditions like rickettsia, we would tell them not to use it with a calcium preparation, not to give it with milk, because they form insoluble complexes with these compounds. The same thing with quinolones. The efficacy of quinolones, see, I do make mistakes in my slide because it is human to err. And I want you all to point out mistakes because it is more human to point out mistakes. So when you talk about quinolones, there is a spelling mistake there. The quinolones bind to anything which is 2+. So if you have iron, if you have zinc, if you have calcium, if you have magnesium, you have aluminium, it just binds to them and again gets chelated. So it is both ways. The efficacy is lost, and they also prevent these elements from getting into your system. And that is why the general practitioner, who was more complete in his prescription, he had given one for epigastric distress, he had one to maintain the microbiome, and he had given an NSAID so that it would take care of the fever. Still, it did not work because they were inhibiting or antagonizing each other. So once you get chelated or insoluble forms, they don't work. And we all know penicillamine is a chelator. So when we do use penicillamine for conditions like Wilson's disease, you also need to look at zinc status because they don't differentiate between copper and zinc. Then the luminal losses. So we do have a lot of drugs that can prevent certain things from getting in. For example, sulfasalazine that we use in a number of GI conditions. This can cause a loss of folate. Belongs to the sulfa drug, and we do know that when you have this combination of sulfa trimethoprim that we use so much today, it is basically by action on the folate synthesis. In fact, we even use it for lice. So when you have a resistant lice, we give a single dose of cotrimoxazole, and that is, it comes in the blood, it's sucked by the lice, and bacteria in the lice's gut is destroyed. There is no folate production, and the lice perishes. It's a very long story. So I'm not asking you, I'm not promoting trimethoprim for pediculosis, but what I'm trying to say, the mechanism of action is through folate synthesis. So folate losses. Zinc, we all know, it competes with copper for the metathione porters in the intestine. So it again blocks the copper, and there is extrusion of copper in the gut. And that is why we use zinc in Wilson's disease. Then we have steroid. Steroid, like I told you, yes, calcium losses in the gut. Mineral oil, even today we use mineral oil in some of the resistant cases of constipation. Though PEG has reached right on top, there was a little bit of scare of PEG and anaphylaxis during the COVID vaccine, but now we know those were stress-related reactions and nothing to do with anaphylaxis. And PEG still has its top role in the management of functional constipation. Mineral oil still works in a small subset of patients. And we all know that in mineral oil, which is not absorbed, which is not digested, you could have the fat-soluble vitamins dissolving and getting lost, as well as it is going to increase peristalsis and increase motility. So you may have a number of nutrients being lost because most of the absorption is at the level of the small intestine, and everything here gets extruded into the large intestine. Luminal changes. Today, there is so much of talk about cancer therapeutics and microbiome. Why is it that some drugs work better in some people and some don't work? And now they know that it is the altered Firmicutes bacteroidetes ratio in the gut and certain microorganisms like Faecalibacterium and Akkermansia and certain bacteroidetes group, which are responsible for the efficacy of certain cancer therapeutics. A big study is being done even in our Tata Cancer Institute. And the biggest paper came out that immune checkpoint inhibitors and their action when the microbiome was altered. We also know that a number of drugs work well with certain microbiome. The toxicity is more with certain microbiome. Digoxin toxicity with the Egertella microbes, the paracetamol toxicity and sulfation pathway and the cresol pathway and certain Clostridia. So there is so much to do with microbiome and drugs. Now let's come to something which we use, I wouldn't call misuse, and overuse. PPI, H2 blockers, and antacid. We have a binge, and then we end up taking one of this. Alcohol, binge, and taking one of this. What we need to understand is the conversion of pepsin or pepsinogen to pepsin requires acid. So when you have indigestion, it is stupidity to take an acid blocker. Food is the best acid blocker or something that dilutes the acid. Never use a PPI because a PPI is going to knock out the proton pump. It's going to take a lot of time for the proton pump to be regenerated. H2 blockers, God has been kind. There is something called as tachyphylaxis. It works for the initial few days, but then the side effects remain and then it doesn't work. So that's called as an acute on chronic tolerance. And antacids, aluminium, magnesium, all types of salts that are used to coat the gastric mucosa. And one of the best here is the sucralfate, which only coats on the ulcer and requires the acid for its action. But what is the problem when you bring down the acidity or increase the pH in the stomach? So when you increase the pH in the stomach, things like vitamin B12, vitamin C, a number of other vitamins, iron, calcium, magnesium, chromium, phosphorus, especially chromium and phosphorus are linked with antacids. The first 1, 2, 3, 4, and 5 are linked with PPI and H2 blockers because they have to be extruded from the food matrix and then should be available for the transporter system to take it in. And for that, you require the acidity. And this is the mechanism for B12. And we do know that if you don't have the HCl there is no conversion of pepsinogen into pepsin. This breakage of B12 from the dietary protein and availability for the intrinsic factor is not there. And then comes your absorption. Iron, again, we all know ferric to ferrous, and we also know that the pH has a role in the hepcidin cycle, that a high pH will definitely impede the transport of iron into our system. Magnesium, calcium, and vitamin D. Why I have stressed on all this? Because they are all interconnected. In medicine, most of the things are interconnected. And for your parathyroid to bring you out of crisis, it requires magnesium. So a parathyroid functioning is totally dependent on magnesium. And if the pH goes up and your D, calcium, and magnesium are not well absorbed, it is going to be a problem as far as your bones are concerned. And there were many studies in the past about fractures and use of PPIs. This is something which is extremely interesting. Gastric juice, very rich in vitamin C. And this is not only a very powerful antioxidant, but it takes care of the nitrites load in the upper part of the intestine. In the lower part of the intestine, it's taken care of by the microbiome because some of them can be genotoxic. Vitamin C is supposed to be unstable at high pH because it gets converted into a substance which cannot revert back to its original form. And that is why you need the right pH to maintain your vitamin C. One drug that can cause loss of vitamin C is aspirin. So in those days when we used to take a lot of aspirin for a lot of rheumatological disorders, aspirin could cause loss of vitamin C and that required vitamin C supplementation. Then drugs causing motility. This is not at all surprising. Antibiotics. You pick up anything. The macrolides are the most famous. Macrolides and the motilin receptor, be it erythromycin, be it azithromycin, be it clarithromycin, they could all cause increased motility. Antacids, magnesium salts causing motility. Antiemetics, I'm not talking about ondansetron, which causes constipation. I'm talking about metoclopramide and domperidone, which have the propensity to cause increased peristalsis, increased motility. That's why we use it in a number of motility studies also. Then iron. Iron can either cause constipation or it can cause loose motion. So what happens when your motility increases is, if the train doesn't stop in the station, you cannot get the goods out. So in the same way, when the motility goes up, there is a loss of nutrients because absorption cannot take place because of the short transit time. Then comes constipation. Today, this is called as the cologastric break. God has been very kind that when you are grossly constipated, your appetite goes for a 6. And this, the mothers come and tell us in those kids with functional constipation, the day the child passes stools, he has a good appetite. This is called as cologastric break. Iron can cause constipation. Ondansetron can cause constipation. So what we usually tend to do is we tend to start off with a small dose of iron, and we need to know the way iron is absorbed. So we give it on an empty stomach. We give it with a limbu pani or vitamin C because absorption is almost double, and also the so-called ferrous and ferric conversion is there. And in a small percentage of people, we end up with constipation. There we could give it even once a week because the absorptive capacity is much more in the deficient people. Oxybutynin is used in bedwetting, especially with a small bladder capacity and an irritable bladder, where we first treat constipation and then give this. It's a very powerful anticholinergic drug. And if you have not treated constipation before you start off with oxybutynin for bedwetting, it's criminal. Then we have codeine. We don't use codeine any longer for pain or for as a cough suppressant, but folcodeine was available a few years back and still available in some preparations as a cough suppressant. It does have the potential to cause constipation like all opioid derivatives. So when you are constipated, the problem is the transit time is prolonged. When the transit time is prolonged, certain things that have to be absorbed at a different place are still waiting to be delivered there. Second, the microbiota goes for a 6. So pathobionts tend to bloom. And there is always, the pathobionts also require vitamins. They also require minerals. And that's why we never give iron in an acute phase or even in the recovery from an acute phase, because iron is needed by most of the microorganisms. Then comes mucosal integrity. We do know that you need an intact mucosal system. The mucosal system is very interesting. You have an outer layer, an inner layer of mucus, then a layer of cells. And then you have the biggest immune system on the other side called the gut-associated lymphoid system. Now, when you use drugs like anti-cancer drugs, the non-steroidal anti-inflammatory drugs, they basically affect the cycle, the cell cycle at the gut level. So prostaglandins are needed for epithelial regeneration. And if you block the epithelial regeneration by COX-1, COX-2 inhibition, it's going to cause problems. So also with chemotherapeutics. And why I have put metronidazole in red is because there is so much of an overuse of metronidazole. Anybody with a chronic abdominal pain is given metronidazole. That's criminal. You have to restrict the use based on what you're treating. And metronidazole is one agent which can really thin out the outer and inner mucus layer, so predispose you to translocation and to change the state of the gut from controlled inflammation to a little more than controlled inflammation or a pro-inflammatory state. So metronidazole is something you use only if there is an indication, like you have an EH sitting there, or you're probably treating it for a C. diff, an antibiotic-associated diarrhea, or an anaerobic infection. Metabolism, yes, it's a separate topic by itself because you have transporter systems that can be affected. Like I told you, see, right in the beginning when Ram was talking about what made him ask me to make a presentation was because when we talk about drugs, we need to know that the interaction between the drug and the nutrient is bilateral. So if I'm taking fexofenadine interacts with apple juice. So we never used to have an apple juice in the past, but now with the real pharma in the market, we have all real juices. And all these real juices have an extra calcium in them, the added calcium in them. So remember, you take a ciprofloxacin with a real juice, the calcium is going to block your ciprofloxacin. You take an apple juice with a fexofenadine, it's going to extrude the fexofenadine fast by the P glycoprotein system. So there is an interaction even at the transporter level. There is an interaction at the cytochrome level, the CYP level, and you have so many CYPs. The most important one is CYP3A4. And this is the commonest enzyme metabolizing about 40% of the drugs. And you have inducers and you have inhibitors. The inhibitors are very dangerous because one dose is enough to inhibit. So the levels can go up. Whereas the inducer takes time to increase the metabolism of a drug. And AKT, rifampicin, Isonex, they are all inducers and inhibitors of the cytochrome the 3A4 system, and you need to be very careful. So statins and metformins, very high on the list as far as metabolism goes. That's why you get these statin-induced myopathy. You have metformin with lactic acidosis. They're all through the metabolic pathways. And we know these things. We know Isonex affects B6 and indirectly affects even niacin. So because it affects B6, we supplement all patients on isoniazid with B6 because we know it is going to happen. And indirectly on niacin. So what basically happens, you keep looking out for the 3Ds, pellagra, diarrhea, dementia, dermatitis. And when you start seeing photosensitivity, you may require a niacin supplementation also. We also know about valparin and carnitine. We are extremely scared the fatty acid oxidation pathways when there is a defect and how valparin can cause an acute hepatic necrosis. Valparin probably also affects biotin, B7. And one of the side effects of valparin is hair loss, alopecia. And that responds dramatically to biotin. So we start giving biotin along with valparin because you don't want alopecia. So valparin with biotin, not only at the luminal level, but may also be at the microbiota level because a significant amount is produced from the microbiota. Methotrexate and folate, we know them as antifolate drugs. And the enzyme inducers, like I talked about, rifampicin, steroid, they all are enzyme inducers, but they take time to increase the metabolism of a particular nutrient. Excretion, common sense, diuretics are going to throw out everything, but we know a loop will be throwing out sodium, potassium in a big way, we need to supplement, water in a big way. We do know the thiazides keep the calcium inside, so when you have a hypercalciuric state, we give thiazides. We know the furosemide is going to throw the calcium out also. So we need to understand all the things that come out when you use diuretics. The B complex come out in diuretics. And when I give you a few case presentation towards the end, I would be talking about diuretics and B complex coming out. Laxatives, we know about it. Everything needs to, this is common sense out here. And see the list of vitamins. So you could have a vitamin A, which could be brought out by orlistat and bile acids, sequestrant like cholestyramine, cholestyramine. You could have vitamin D, which is affected by the old anti-epileptic drugs, phenobarb, phenytoin, carbamazepine, and corticosteroids. Vitamin K, here I need to emphasize that when you're using antibiotics with the NMT chain, like cefoperazone, it's used by this pediatric surgical people in a big way. You need to understand, because of the similarity of the side chain, the recycling of vitamin K is stopped. And these are the kids who may have a hemorrhagic tendency. And you may have to supplement vitamin K at the end of a long course of antibiotic. And look at B1 coming out with furosemide. We know about B3 with isoniazid and pyrazinamide. We know B6 with isoniazid. But we also have a levodopa coming into play, theophylline and cycloserine, B7 with anti-epileptic drugs and lipoic acid. A lot of patients, the adults, are on lipoic acid preparations for diabetic neuropathy. They need to take B7 supplements, that is biotin. B9, methotrexate, sulfonamide, anti-epileptic drugs. B9 is folate. B12, metformin, definitely yes. And if you are going to be on long-term proton pump inhibitors for whatever cause. So we need to understand that when you treat your patient, suppose you're treating a hole in the patient, you need to treat the patient with the hole and not the hole in the patient. So what I'm trying to say is, know all the comorbidities, know the patient in great detail before you jump into a prescription. What are we missing out on? This is what my teacher would always teach me, Dr. Abdekar, that when you are going to treat anyone, understand the genesis of the problem. Rationalize therapeutics based on whether he will be able to take it, compliance issues, efficacy issues, and cost issues, ESC. So you require efficacy, safety, cost, compliance, and never forget the collateral effect. Anything untoward happens, think of collateral effects. Respect your drugs, know your patients. And I'll just discuss a few interesting cases, Ram, if it is okay, before we close it. So this happened actually with my dad. So my dad has got Parkinson's and he has this false dentition, and he used to stick it with a preparation called Fixodent, which has a lot of zinc in it. So it's a glue with which the artificial dentures were stuck onto the mandible and maxillary arch. And the only problem that happened with him is he had so much of bone resorption that he had to do it 3-4 times in a day. And what happened is he started developing a type of anemia wherein he had a picture just like iron deficiency anemia, but that neutropenia was very, very prominent. And the iron studies were okay. And we were wondering what it is. And then we came across an article which said excess of zinc, low copper, following glues used in dentistry. And then when we read, yes, the sideroblastic anemias can make its presence just like an iron deficiency anemia, we stopped the glue and we stopped the artificial dentures for some time and he improved. So this is a classical example of zinc causing copper deficiency. And if you go through papers, zinc gluconate was used during the cold season in the European countries because it reduced the common cold by a significant amount, that is by 4 days in their studies. And what they started seeing is people started using the zinc gluconate for longer periods, and they all started getting an iron deficiency like picture, in addition to everything under the sky. It was ivermectin, it was zinc, it was an anti-rheumatic drug. God, we used to take everything. It even used to be a Patanjali product there without knowing anything because there was so much of panic. And then zinc is being used for almost everything, even in acne. So you need caution because you need to know that they have another side to it. This happened during my postgraduate time. I had a child who was PEM with a ventricular septal defect with a refractory failure. And this child would not come out of it. And we had some wonderful people at that time who had come and assist this child from the cardiology department, who are now very well-known figures in pediatric cardiology. And I was very lucky to have one more great pediatrician, Dr. Barjor Barucha. And Barjor walked in and he told us, just give this child B complex and we'll have a look. And this child dramatically improved. And then he tried to explain to us, because we were so keen to know why did it happen. He said that when you have a refractory failure in a PEM and you are giving diuretics like furosemide, think of B1 deficiency. And there it was. So what all these are trying to tell us is we need to look, we have to think beyond the box. It's very, very essential when something funny happens. Then we had this child who had just graduated from the NICU, who had received cefotoxime and amikacin for a long duration for a gram-negative sepsis, and had now developed fungal infection in the form of a fungal ball and was put on amphotericin B. And he developed an arrhythmia, and we were just not able to get him out of the arrhythmia. His potassium level was pretty low, and he was not responding to potassium. And that was the time we gave him magnesium, and he came out of it. So for the potassium to work, it also requires magnesium. And we were wondering, agreed, that his potassium was low because he was on hypotonic, because in those days it was all hypotonic fluids. It was 1/5 glucosaline. There were so many drugs going on, amphotericin B causing potassium loss, and potassium was one thing which we used to look for. But what we didn't understand is aminoglycosides like amikacin can cause a significant loss of magnesium through the urine. And that exactly had happened. And the OC pill. The OC pill can cause any deficiency. So if you have a patient on an OC pill, the oral contraceptive pill, who complains of breast tenderness, give B6. Has migraine attacks, B2, riboflavin. Has a thromboembolic phenomena, you start thinking of calcium, you start thinking of vitamin D, you think of folic acid, and you think of B12, because the homocysteine comes into play. So what I'm trying to say is they respond to these micronutrients. And what is very important when somebody is started on an OC pill, that they have to be told that it causes folate deficiency. And today we know that midline defects, neural tube defects, orofacial midline defects, cardiac defects are all related to folate deficiency. And periconceptionally, we give folate supplementation. So this is something that we need to educate people about. And the last slide is my grandmother. She rocks. And I am saying that with a reason. No, Musambi juice was the only thing that we used to get when we are sick. We never used to get it when we were fine. Just like ice creams we used to get when the tonsil was removed and we had such a painful throat or a nodinophagia. See the properties of Musambi. Low in acid, but has a significant amount of micronutrients and extremely rich in vitamin C. I'm not talking about the real juice. I'm talking about a really made Musambi juice. Then we used to get our vegetable soup. We used to get, every illness was followed with a B complex tablet or a syrup. And my neighbor who used to be in KM hospital, the toilet had a common drain. So the other person could see your urine coming out to that same common drain. So if you had B complex, you would definitely know, oh, you're on rifampicin. Oh, you're taking B complex. So that's the way it is. And then we had one more system in the house that we had to sit in a chair in the balcony in the afternoon, post-illness. So you got your vitamin D, you got your B complex, you got your micronutrients without evidence-based medicine. Amazing. We need to follow what the grandmother taught us within inverted commas. And a few references. This is a must. We need to read and we need to spend at least 15 minutes every day to read some article or the other. This is from the American Journal Annals of Clinical Nutrition and Metabolism, an excellent article on drug-induced vitamin deficiency. And this is guidelines on PPI stewardship from the Indian Journal of Gastroenterology 2023, because there is so much about antacids, H2 and cancer, proton pump inhibitor. Because see, acid is the first line of defense. If I have a pani puri, I am protected from the salmonella because of my acid. Unfortunately, I go home and I take my PPI because I've had too many pani puris. And you are getting rid of the good things that the acid can cause for you. Thank you. Thank you so much for a patient.
Thank you so much, sir. Actually, when you were talking about all these gamut of drugs, what crossed my mind was circuits dialogue. कि तोड़ने से पहले कभी सोचा था क्या कि कितने हड्डियां होते हैं बॉडी में. So before writing the prescription, I think we all have to really go back to our basics, our biochemistry, the pharmacokinetics, the pharmacodynamics, and the pharmacogenomics, of course, in this era of precision medicine. And then we have to write each and every drug, be it even a Lanzol Junior, sir. So thank you so much, sir, for enlightening each one of us. Sir, there are few
The
questions.
most important thing is when you pen a drug, you need to know all about the drug before you pen it. For example, if I'm writing paracetamol, I need to know I need to give it on an empty stomach. My dose comes down to 10 milligram per kilogram if I'm treating somebody with HIV or a protein energy malnutrition, or where I feel grossly undernourished and there is a problem with the redox potential. I need to know that even though it is relatively safe in pregnancy, if a pregnant mother takes it, she can still produce a baby with an undescended testes. So there is so much to medicine. There is no full stop. And medicine is to get rid of the old things and start learning once again. So it is this relearning process which I've learned from my teacher, Dr. Ambedkar.
We all, sir. All of us, sir. Absolutely, sir. So with your permission, can I take few questions?
Yeah,
from
please,
the
please.
questions? So, sir, there is one question on metronidazole. As you have mentioned that there is an aftertaste. So is there any way out for that aftertaste, sir?
No, there is no way out. All imidazole derivatives. See, the compliance with imidazole derivative. When I say imidazole, it means metronidazole, ornidazole, tinidazole, secnidazole. All these have gone down the drain because of the aftertaste. The second thing that we need to know about metronidazole is it causes chromosomal breaks. How many of us even know that? So in an individual who's got a tendency to chromosomal break, you don't use a metronidazole. And I see prescriptions where metronidazole and meropenem are used together. For what reason? There is no C. diff sitting there, both for an anaerobic infection. So why people shifted from metro to secnidazole is because secnidazole was a single dose. So you had to suffer only for 1 day. Then they came to tinidazole, 3 days. Ornidazole, another shorter course, whereas metronidazole was a long course. But the metallic taste, there is no way you can get rid of it. And the headache.
Yes, sir, definitely. So, so there is something which, I wanted to ask you. So you have mentioned about going back to our basics and about our traditional diet. So when you are writing your prescription and when the mother asks you that, is there anything in the diet, which I should be giving to the child? It's a very tricky question for all of us. So do you spend time on that as well?
So that is something that's very essential. So I have changed as a practitioner after being with Dr. Ambedkar. So initially we used to deal in numbers. Now it's more of quality rather than quantity. So what we do is we spend a tremendous amount of time in counseling. So when we get into diet, that is one place where you can spend a lot of time. Because you see, what happens is when you have a child who comes on day one with very high fever, you have nothing to offer. It could be anything. It could be viral fever, it could be a dengue, it could be malaria. You could just tell them what it could be, and you could spend time on diet. So when you spend time on diet, one thing where I feel we are all missing out on is how to cook. So even if I'm going to make a soup and I want my micronutrients to remain, I need to cut my vegetables big. I need to cook them in a cooker. I need to grind them in a mixie, strain it. And then I need to tell them that if I want my micronutrients, including iron, coming out from it, add a dash of lemon. So there is a way. It is not just nutrition. There is nutritional economics. There is nutrition, how you go about it. And there is so much to it. Even sprouting. See, like I told you about phytates. Our diet is very rich in phytates, which takes away most of the nutrients. But the other side of phytates, very powerful antioxidant. But if you want to bring down the phytates, we soak, we sprout, we ferment. So that's the way we bring down the phytic acid. So I think we need to sit in. And Ram, I was also talking to Ram about how you should not be taking certain things with certain things.
Yes.
So if you have a citrus juice, please don't take your atenolol with it. The efficacy comes down. And you don't blame your hypertension for not coming down and that the drug is not working, because the so-called grape juice and interactions and CYP3A4. So there are so many things about food and food-drug interactions, which is even a bigger gambit than prescription-induced nutrient loss.
Absolutely, sir.
Its best thing is with water, upright position, and lots of water. But there are things, suppose you want to take your lumefantrine and artemether during the malarial time, like now, you give it with basundi. Because a fatty meal doubles the absorption. Cefuroxime is with food. Cefixime is on an empty stomach. So everything, there is a way to go about it. So know everything about your drug before you pen it.
Yes.
Sir, you said something.
And just read one particular slip every day. That's more than enough. By the end of a month, you know 30 drugs.
Yes, sir.
Sir,
But
you
there are
said
better
something
things
about
too, I know that.
tomato ketchup also, when not to eat. With what food you should not eat tomato ketchup? You had said something.
Yeah, so we were talking about acidic foods.
Yeah.
So when you have an acidic food, it can basically get rid of alkaline substances. So that is a concept of acid with alkali. So same thing then in prescription-induced losses. What I was trying to say is to bring up the pH, acidic drugs will not get absorbed. If you want them to be in dissolution and in a good state, you require an acidic environment. Vitamin C, for example, acidic.
Yes, sir.
Sir, can I ask you one question?
Yeah.
Can we give vitamin B supplement to the children who are purely vegetarian without doing the B12 level?
So what I was trying to tell you is today we are talking about microbiome and synthesis of B complex. So anything that messes the microbiome can give rise to a condition called dysbiosis. So what is dysbiosis? Dysbiosis, pathobiont bloom, the wrong metabolites in your gut, and the numbers are low and there is no diversity now in the gut. So it's a state of chaos, and microbes are also like human beings. There are producers and consumers, and the excess is absorbed by the body. Fine, so it is like that. And B complex, we don't have much of a pool in the body, except like B12 has a huge pool in the liver. But otherwise, B complex, you don't have much of a pool. And the amount that you get from the microbes is still minuscule. Please note, don't think that you can get everything from your microbiota. You have to get it by the normal way. The major absorption is at the level of your small intestine. So the absorption from the large intestine is negligible, because today we blame the clean water for B12 deficiency. Because previously in Bombay, we all know that the water, there are two pipes running, one which gives you drinking water and the other which is the feculent water, and they can easily mix. And probably the flora that you get from there is responsible for your good microbiota. It's no longer like that. So you do require B12, and there are certain clues when you start thinking about B12 deficiency. Now, in infancy, you have a child who's got a little bit of tremulousness or the infantile tremor. And you look at the child and you look at the mother, and the mother has vitiligo. So she has an autoimmune condition. Check her up for pernicious anemia because the B12 stores are huge. For you to get B12 deficiency, it takes a long time. So that's the way you start thinking about. You're on metformin for a very long time, or your dose has increased from 500 OD to 500 BD, and now you're on 500 TDS. Yes, you require supplementation because you are prone to that sort of a thing. So, and a pure vegan, again, you need to supplement them with B12. But what we are trying to tell you is we were taught in the past that water-soluble vitamins, no side effects. There are effects. Like I told you, B12 and acne. Excess of B12 can give rise to acneiform eruptions. And you know, one of the organisms producing B12 is Propionibacterium.
No.
Sir, one question, sir.
Yeah.
What about this? Nowadays, people are recommending alkaline water. Any idea about it?
I won't comment on that because, like I told you, every question may not have an answer, but every answer, I mean, what I'm trying to say, it's very difficult to answer certain things where there is no solid evidence. So there are people who are getting into a vegan diet, totally into a ketogenic diet, into alkaline water. So I don't know gluten-free diet, and some have done very well. So we require something which is more concrete before we jump into any of these. So even the thing that I was discussing with Ram was whether we could combine an alkaline and an acidic thing together. Like there are a lot of people who would mix limbu pani with honey. If you catch hold of an Ayurvedic person, you would say viruddha. They are totally incompatible. And we mix everything and we feel it's good.
Sir,
There
one
is
more
one
question.
question. Yes, sir.
Sir, you said that aspirin reduces the absorption of vitamin C. So the patients who are having a cardiac disorders are on long-term aspirin every day. Should be supplemented with vitamin C?
No, you need not supplement. No, you have your daily fruit. That's more than enough. Okay, when you're not eating fruits, that is the time when you have problems because vitamin C is not synthesized in our body. You require it to be supplemented. The natural form is better than the tablet. Why is it better? If you open the vitamin C tablet, gets exposed to air, the potency is lost. One. Two, if you take vitamin C in excess, you can be prone to oxalate stones.
Thank you, sir. Yes, Ripa.
Yes, sir. There is one more question. It is about another supplement commonly used, calcium supplements. The question is, can you please let us know about calcium? So I think they are pointing towards when should we prescribe calcium supplements.
So again, what we basically do is calcium, magnesium, zinc, vitamin K, vitamin D, they all go together in bone mineralization. So now you have a lot of preparations which have all of them in one bottle. You have calcipenic individuals and you have patients who are adequate in calcium, but they're starting to be deficient in vitamin D. So this is again an endocrine topic, which I don't want to jump into. But what is needed to be understood here is when you are on steroids or when you are on the old anti-epileptic drugs, we would supplement both calcium and vitamin D. So we used to supplement calcium, phosphorus, and vitamin D. And the old preparations used to come in as suspensions. So again, we don't spend time with our patients. You need to tell them that they have to shake the bottle before they take it. Otherwise, you have the water on the top and the powder right behind.
Yes, sir. So there is one question on good bacteria, the prebiotic and probiotic. So, amongst Rhamnosus, GG, Saccharomyces boulardii, Lactobacillus, which is to be used during diarrhea?
So that's why we are coming into a concept called as enterotype. Just like you have blood groups, we have an Indian enterotype. The Indian enterotype is why we are talking so much about probiotics, and this question mark is basically because extrapolating European data on Indian data is not right.
Correct.
You need to have proper randomized controlled trials on susceptible individuals to show that they are beneficial. Since we don't have significant studies, we have still not come to a consensus. That is why the ISPAGAN, the Indian Society of Pediatric Gastroenterologists, have not recommended anything. But if you take the ISPAGAN, they have recommended Lactobacillus GG for viral and Lactobacillus and Saccharomyces boulardii as one of the main ones for antibiotic associated diarrhea. And that is common sense when you read the mechanism of action. In our country, what has happened is the bacillus strains live the best because temperature is an issue, storage is an issue, and lactobacillus and bifido may not survive if they are not being packed properly and not got from the right place. Whereas the bacillus species are in the spore forms. So, and that is why the market has gone up from 1 rupee to a 200 crore market without much publicity. And we have a lot of studies which are not real big studies, which do show that they have all the mechanism of action for viral diarrhea, for antibiotic associated diarrhea, and for dysbiosis. So before you jump into any live microbial therapeutics, you first need to understand, do I really require them? Because it's a live organism. Second, if I'm going to use the organism, has the genome been decoded? Number two, do I have the antibiogram? Because if that gets into my system, if that organism gets into my system, I need to know what antibiotic I can use. So if my Saccharomyces gets in, I know I can use an azole. If my lactobacillus gets in, any penicillin will work. And if my bacillus gets in, I know vanco by mouth and a quinolone by IV line will take care of it. So you need to know everything before you prescribe, and then there has to be a need for it. Just don't prescribe to add on to your prescription. That's what my first slide tried to tell you.
Okay, sir. And so now many questions are pouring in. There is a question on B12 again. What is the cause of B12 deficiency in teenagers?
I think you require a hematologist to tell you that. I really don't know, but let me tell you some very interesting study because I was a part of this study. We were following up mothers, neonates for up to the age of 16, and we were doing a study on obesity, and I was called in to do the sleep study in these kids, and they were all IUGRs. And what we did find in all these IUGRs was tremendous amount of visceral obesity. And what we all found in all these mothers was they had the B12 deficient phenotype. I forget the name of the main person from Pune who was doing this study. Yagnik was the person. Amazing study, 16 or 19-year follow-up study, wherein obesity and we only talk about supplementation of folate, but we are all deficient in B12 also. And we need to supplement B12.
So that leads to our next question, sir. So for B12 oral supplements, how much is required?
Again, that's a hematologist this thing. But what we do is when you're grossly deficient, we go up to 1,500 units. But what you need to know now is we no longer give the injections. The injections are painful. The injections can have very bad reactions. What we do is we have sublingual preparations. We have intranasal preparations. And both of them give you excellent bioavailability. And they get into your system. And within a week's time, everything is rectified because you also need speed. You can't wait for it to get in and to rectify your system. It has to be done fast. And when you give B12, you give folic acid along with it.
Yes, sir. And so what about prescribing supplements on a routine basis? There's a question that there's been a significant decline in essential nutrients in fruits, vegetables, grains, and pulses over the last few decades. Is this true? And if in such scenarios, is it necessary to prescribe supplements?
So, like I told you, today's basic problem is food. And what we are seeing is there is a surge in malignancy. And we have still not found out the cause for it. But the probable cause is ultra processed food. So, if you want today anybody to be healthy, be it a child or an adult, the two places where you feed the right thing is one, the brain, and the other is the gut. And this Hippocrates had said long time back, everything begins in the gut. So if I'm going to be feeding the right things, I need to feed my microbes. So if you give an ultra processed food, there is nothing for the microbes. So you need a blend of everything. And we need to follow our food triangle. The processed food should be kept out. So what we teach our parents now is ghar ka khana. There is hardly any ghar ka khana. It starts with biscuit, bread, pav, curry, toast. There is a jam and a sauce. There is a tea, a Bonvita, a boost to bring up your height, a Horlicks to get you intelligence. That's ridiculous. And you need to tell them in counseling that I do have a car. If I put the petrol of the aeroplane, it's not going to fly, it's going to stall. So you need to give them examples to make them understand that it's time that we came back to our food cycle, wherein we started giving food the right way. And we need to tell them how to go about giving food also. And I basically feel that supplementations and multivitamins have come in just because of dysbiosis. Because we know today that the epithelial integrity is lost, the transpose systems are haywire, and we are deficient because of losses, not only from our skin and climate change, but from our excretory system like the kidneys and other things. Now, we were discussing hyponatremia. And I basically felt hyponatremia today is not just iatrogenic, but it's also basically because when I felt thirsty, my mother used to give me buttermilk. When I was thirsty, I was given limbu pani with a little bit of salt. Today, if I am thirsty, it's a Tetra Pak. It's an aerated water. It's a caffeinated, sugared water, which is going to cause more diuresis. It is hypertonic or hypotonic, hardly any electrolytes, and you're aggravating the situation. You feel more thirsty. You're going to drink more of it, and you're going to create dilutional problems. And I even felt that when we talk about the holiday system of giving IV fluids, that we need to change it. And it's very true. Like I mentioned right in the beginning, less is becoming more. So really, less is becoming more.
Yes, sir.
It's all tea and toast nowadays. It starts with tea and toast, and it's only on a Saturday night or a weekday night when you eat home food. Rest of the time, it's all binges. And you can get food at any point of time. So you have the Swiggy, the Zomato, the Tomato, and everybody waiting to deliver food. And there is no question of day and night either. I am lucky I wear glasses. I've got a blue light filter. But even then, when I feel that I should sleep, I need to sleep. I don't sleep. It's not just micronutrients. It's basically I've not developed a good sleep hygiene. And the light is there to pollute my sleep. So you have light pollution, you have food pollution, and everything wrong in the market. We need to put a full stop there.
Absolutely, sir. We have to really go a long way. And so what about, is there any relation of obesity and antibiotics?
Yeah. So now we do know that more inflammatory molecules pass through the gut. They generate an obesogenic environment at the level of the liver. And this has been proven beyond doubt. So when you give an antibiotic, one antibiotic that has been studied in great detail is the macrolide. And one organism which has become very famous is called as Christensenella, which is associated with leanness. When you take more than 3 courses of a macrolide like azithromycin, in the first year of life, they have found that these mothers are very happy because these babies are plump and obese. They don't know the repercussions. So it's probably you're eradicating this Christensenella. The second thing is you are creating an obesogenic microbial signature in the gut. So in the gut, you have the 3 big families called the FAB, Firmicutes, Actinobacteria, and Bacteroidetes. When you alter the proportion, you have microbes that assimilate more. And you know, we human beings have the thrifty gene. We like to accumulate. So when you have a genetic propensity and you have a microbiota which also is going to assimilate, and you have a controlled inflammation becoming pro-inflammation because of the LPS going in through your, that is the lipopolysaccharide endotoxins going in through your gut epithelium, what is known as the leaky gut, you are bound to get it. Now, there was a very interesting study that when you take carnitine is like red meat, for example. People who take red meat, they found two subsets. One who developed an accelerated atherosclerosis. And they found that they had a set of microbes that generated something called as trimethylamine, TMA. And this got into your system and became TMAO, the oxidized form. And this is highly atherogenic. And when they changed this microbiota, they found that accelerated atherosclerosis, they could put a full stop. So this is just a small study. And today we know that we have done something as the fat transfer study in mice. So we picked up the lean mice and the fat mice. We removed the microbiota from the fat mice and put it into the lean mice. The lean mice became fat. So we know the microbiota plays a role. It's not alone. Everything is interconnected, but it does play a role. And also the ultra-processed food, there are lots of endocrine disruptors. Plastic, for example, bisphenols. We don't know what all distant effects they have.
Yes. I think so. The wealth of knowledge you have with the session should not end, sir. But we request you for a part 2 from on behalf of Maha IIP. I am only requesting you for a part 2 with permission of Ram, sir. And
Definitely, I think still a lot of
I thank Ram from the bottom of my heart for giving me all the importance. I apologize profusely for refusing such a brilliant platform, but I definitely want to take back that word legend, which I really thought of putting a disclaimer that I'm a general pediatrician sharing my knowledge on a sharing knowledge platform. Each one is brilliant.
Sir,
Each one has a box of ideas.
Sir, all the legends, they always say that we are still students. But you may be student for yourself. For us, you are legend.
yes,
So
sir.
that the terminology is for the common pediatrician, that they are learning from the legends, not for you, sir.
Thank you so much. Thank you. Thank you very much, Ram. Thank you, Reepa, for all the importance.
Thank you so much, sir. So I would just like to say one Sanskrit line, Vidya Dhanam Sarva Dhanam Pradhanam. And so you have been very kind to share your most important dhan, which is your knowledge and wisdom with all of us on this intriguing topic. It was such an eye-opener. And definitely now, whoever has attended this session from tomorrow when they write the prescription, at least they will think for a moment and then they will pen it, sir.
I hope
Thank
so.
you so much, sir. Yes, sir. Thank you so
Took me
much.
some time. I hope so. They do it early.
Sir, definitely, I would like one more session. Maybe we can call it a different diets in different chronic disorders.
Yeah, we'll do something of that sort. Ram, Dr. Anand is there from Bangalore. He's one of the senior most pediatric ENT specialists from that place. He runs an allergy immunology course. And he's like the Amdekar on that side, Dr. Amdekar on that side.
Welcome, sir, on the Maha IP platform.
Thank you, sir. It's a wonderful session. Fantastic. Dr. Sridhar is amazing. I always like to call him as the walking medical encyclopedia. He's so good. And he's very, very dear to me. Thank you for providing us this opportunity.
Thank you, Dr.
Thank you, sir.
Thank you.
Dr. Anand Garu, it's a very educative and informative. We really wonderful. We never heard this type of lecture in my life.
Thank you, Shingari. Thank you so much.
For those who have missed the session, we have an YouTube live and the session would be there on the YouTube. If you put the Maha IIP, the terminology is Maha IIP YouTube, you can listen on the YouTube also.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, Ram. Thank you, Reepa, for all the importance. Thank you very much.
Thank you, sir. Thank you so much.
Okay.
Thank you.
Yeah.
Thank you.
Good
Thank
night,
you to
sir.
all the delegates for joining. Thank you so much.